Hello, and welcome to the debate on standardization of evidence-based practices. My name is Pamela Wood, and I will be moderating this debate today. My duties include running the PowerPoint, but I want to pre-warn you that the PowerPoint is only going to show a working view and not the full screen when I post it because I have technology issues. So I apologize, but I will also post the PowerPoint into the discussion board underneath the video so that you guys can reference back to it when you're doing your debate discussions. Another duty that I have is to introduce the people who will be speaking for the debate and then to restate their points when they're done speaking so that you guys have you remember the first point and the second and the third, as well as the last ones that you heard during the debate. Today's debate will begin with the pro side, and our debaters today will be Mary and Sarah for the pro side, and then our con side will be Kirsty and Jessica. So to begin our debate, Mary will present the stator points.
Hi, my name is Mary Catherine Bugle, and I will be presenting the points for the pro side. The points that I'm going to cover are ethical responsibility to provide highly effective treatments supported by research, uniformity. The second one will be uniformity across all settings involving the client. The third will be success within the ABA field, and the fourth point will be replication. So I'll start with my first point, which is ethical responsibility. There's an ethical obligation to use treatments that have the most effective results for the clients being treated by the BCBA. According to Compliance Code 2.09a, clients have a right to effective treatment. Behavior analysts always have the obligation to advocate for and educate the client about scientifically approved, supported, most effective treatment procedures. Effective treatment procedures have been validated as having both long-term and short-term benefits to the clients and society. According to Compliance Code 2.09c, in those instances where more than one scientifically supported treatment have been established, additional factors may be considered in selecting interventions, including, but not limited to, efficiency and cost effectiveness, risks and side effects of the intervention, client preference, and practitioner experience and training. Ethically, we are required to provide effective treatments. We often utilize treatments found in the National Standards Project, which have been created to give the user a guide of what practices are effective and most appropriate for the clients. The second point I'm going to make is that there is a need for uniformity across all settings involving the client. This could include, but is not limited to, teachers, behaviorists, occupational therapists, and etc. All these different therapies need to follow the same standards so they are able to work together for the benefit of the child. All therapies should be using evidence-based treatments, and creating a standard list will allow the professionals to use the most effective evidence-based treatments. Having a standard list would increase collaboration between various fields where often there is a disconnect. The Behavior Analyst Certification Board's Professional and Ethical Compliance Code for Behavior Analysts states the requirements for their professional certificate holders to uphold certain ethical standards. According to Compliance Code 2.03b, when indicated and professionally appropriate, behavior analysts cooperate with other professionals as in a manner that is consistent with the philosophical assumptions and principles of behavior analysts in order to effectively and appropriately serve their clients. According to Code 2.09a, clients have a right to effective treatment. Behavior analysts always have the obligation to advocate for and educate the client about scientifically supported, most effective treatment procedures. Effective treatment procedures have been validated as having both long-term and short-term benefits to clients and society. Also, according to Compliance Code 2.09c, in those instances where more than one scientifically supported treatment has been established, additional factors may be considered in selecting interventions, including, but not limited to, efficiency and cost effectiveness, risks and side effects of the intervention, client preference, and practitioner experience and training. The third point I'm going to make about why standardized evidence-based practice is needed is that there's been success within the ABA field. The Behavior Analyst Certification Board has been using a variety of standardized lists to pull evidence-based treatments from and have research proving the success of those treatments. There are a lot of articles targeting a variety of behaviors across several different populations. Within the field of ABA, we have defined what should be targeted and how to monitor and determine what interventions should be used. Our guiding principles follow the 7 dimensions listed by Baer, Wolf, and Risley. These 7 dimensions are the backbone of ABA. And finally, the last point I'm going to make is replication. Once the interventions have been standardized, there would be less wasted time having to consult about methods and interventions that are used in our field in one field versus another. All professionals would have access to the standardized list of evidence-based practices. If the professionals have further questions because the practice may be out of their realm of expertise, then they could consult and specifically ask about a treatment they found in the standardized list. Replication is one of the hallmarks of behavior analysis. If an intervention cannot be replicated and shown to have the same results or a similar trend, then that intervention is likely to not make it into our evidence-based practices. Interventions that have been proven to be effective are the interventions that should be used for children with disabilities. Thank you.
Thank you, Mary, for your comments. I just want to go back over her points one more time. Ethical responsibility to provide highly effective treatments supported by research, uniformity across all settings involving the client, success within the ABA field, and replication. Now we're going to hear from our con side, and Kirsty will be presenting the starter statements for the con side.
Hi everyone, my name is Kirsty Wineland and I'm going to be talking for the con side. I have topics of limited resources, which include training, time, finances, language barriers between professions. Additionally, there's generalizability. The third point would be implementation accuracy. And fourth point is devalues and de-emphasizes professionalism and clinical expertise. So for the first point of limited resources, it would take an immense amount of time to train and cross-train professionals that have integrated or have ingrained practices. So the training is something that would be very time consuming, and Croft, Malmavera, and Van Telder state that there is evidence from a range of countries and settings that use evidence-based practice by practicing clinicians, which is more restricted by perceived lack of time, skills, and knowledge to apply it in practice than by skepticism about the concept itself. So within the limited resources, there's also this issue of a financial burden. So the cost of creating a review board and training persons to implement the intervention, and also the cost of dissemination, are all things that have to be considered. This would be something that could be very costly if we don't, we aren't able to roll it out right away due to lack of finances. The last point for limited resources would be language barriers by professionals. So each field of professionals have their different type of jargon. ABA professionals may be able to have a conversation about DRO, DRI, DRA, or FR1 schedules of reinforcement, while other, other professionals like OT, PT, speech, and even teachers have their different lingos and different ways that they're able to communicate with each other. So second point that I'd like to make is about generalizability. And this is where with the research, which is most often conducted in a clinical setting. So I have a quote by Smith in 2013 who goes on to explain that overall, although many ABA intervention procedures show considerable promise, the tendency of SSED studies on these procedures to take place in controlled settings rely on study personnel to deliver interventions, and focus on successes may exaggerate the potential benefits of the procedures in practice. So the interventions that are done in these types of settings have greater control over the independent variable, but you lose the ability to see how the efficacy of the intervention is within the natural setting. The third point, I'm sorry, the fourth point, I apologize, is devalues and de-emphasizes professionalism and clinical expertise. So the biggest issue with standardization is that there's this manual-like idea that treatments would be in a one-size-fits-all model. So what happens here is that we're devaluing the professionalism of the field. Mullen and Strainer tell us that one argument against evidence-based practice is that there's this cookbook-like practice, which replaces professional judgment with recipe-like manualized procedures. So there's several issues with this notion, but most importantly is that it does devalue the professionalism in the field. There's a risk that people will pull from the interventions and have little knowledge of how to choose interventions based on functions of behavior. How would we be able to ever come up with new interventions, and who would be responsible for that? There are several interventions in the National Standards Project report for Phase 1. And in Phase 1, there were interventions that only qualified as emerging, but now in Phase 2, they're considered established. So there are also interventions that are being used and have been used that are in emerging category. Would these interventions now become obsolete? Having a manual that houses the only intervention that should be used would also not allow for families to input their opinions and make changes based on family dynamic. This could be problematic because it could devalue the culture of stakeholders. Thanks.
Thank you, Kirsty, for your points. I want to go back over her points one more time. Her first point was limited resources, particularly pertaining to training, time, finances, and language barriers. Her second point was generalizability. Next was implementation accuracy. And the fourth was devaluing and de-emphasizing of professionalism and clinical expertise. Now that we've heard our starter statements from Team Pro and Team Con, it's time to hear our rebuttals. Also, with the rebuttal, we have our salvaging statements are going to be included within that, so they will address points that were made by the opponent and try to make a balance there for you. So first up will be for the pro side, and it's going to be Sarah.
Hi, my name is Sarah Graham. My first point is that I'm going to make is programs can still be tailored to meet the client's needs. Standardization of evidence-based practice doesn't pick the program for us, but gives criteria to make sure it meets BACB standards. It will make it easier for the behavior analysts to choose a plan that will do no harm. There's still room for adaptability. Tristram Smith's article mentions that standardization plans and manuals would need to still be standardized, but yet flexible. BCBAs would use their own expertise to decide which plans will work best for their clients. No plan is going to work across the board in every situation for every client. It's the job of the BCBA to figure out which one will work the best using the best science. Brackenberry actually discusses that evidence-based practice is integrating individual clinical expertise with the best available research. Standardization should make this an easier process, as the BCBA will no longer have to spend time evaluating the quality of the scientific research, if the plan is repeatable or if they are able to implement it effectively. My second point is all plans should focus on the individual. It is the job of the BCBA to figure out which plan will work with their client. Standardization won't take that away, but it takes away the steps of determining if the science can back up their selection. A doctor working on pain management plan for a diabetic patient is not going to give them the same plan that would be for a patient without diabetes, as their needs are different. The doctor individualizes the plan based on evidence-based medicine, clinical expertise, and the individual needs of the patient. My third point is payment and reimbursement can be affected. Standardization will mean that insurance companies might only accept certain treatment plans. However, they already do this. No insurance accepts all treatment for insurance. Autism services are not even covered by insurances in all 50 states. As of 2015, only 43 states required autism services be covered. It is up to the BCBA to work with the client's insurance to come up with the best, most cost-effective treatment for the individual. BCBAs are required by the BCBA Ethics Code 2.04D regarding third-party involvement in services to resolve coverage issues in favor of the client based on their clinical expertise. My fourth point is it shouldn't take longer to train or cross-train, as BCBAs should already be training their staff in order to meet Ethics Code 5.04, designing effective supervision and training. Standardization should actually help streamline the training process by making it consistent and having clear, concise directions that are easily understandable across multiple experience levels. According to Stammer, currently there is no consensus for training staff on implementation, even on the same techniques. The variability of time spent training ranges from like 3 to 60 hours on certain techniques. So most staff aren't properly trained even now, out of compliance with Ethics Code 5.03A and B in regards to supervisory delegation to competent and trained staff. My fifth point is it will actually improve implementation by making it standardized, leaving less room for implementation error, allowing the treatment to speak for itself rather than the competence of the individuals implementing it. The more concise and clear directions are given, the less coaching and feedback the person implementing the intervention would need in order to put the technique into practice, cutting down on the overall cost of training the individual. My sixth point is all plans still need to have generalizations so that they should still be able to work in a variety of environments. In compliance with the core standards discussed by Bear, Wolf, and Risley, generalization is a hallmark of applied behavioral analysis. No practice would be considered evidence-based if it did not have generalization. It also would not be in compliance with Ethics Code 4.07A and B environmental conditions that interfere with the implementation. Standardization should actually improve this by allowing for more clearly written examples of different situations in a larger variety of environments. My seventh point is that it won't devalue or discredit professionalism or clinical experience. Standardization allows the science to speak for itself. The plan can be adjusted as the BCBA sees fit, but as it allows for less error in implementation, it means that it's less likely that the plan won't work appropriately because someone did not implement it correctly. If it doesn't work, it's because the plan is not working for that particular client, and a new one needs to be selected. Brackenberry suggested utilizing EBPs, or evidence-based practices, would actually improve clinical decision-making. Mullen also says that most views of EBP propose a process that is highly individualized, relying on practitioner discretion. Mullen suggested we think of it like standardization of EBPs like using a navigation system in your car. Usually the navigation system will give you several routes to take, highlighting the one that the navigation system feels will work best. However, it is up to the driver to decide which route they're going to take, and factors such as time, speed, scenery, the goal of the trip will help make the driver make that decision. My eighth point is it does have less experimental design. However, it allows for it. It just has to be tested and proven to have some merit based on clinical experiments. Just like in the pharmaceutical industry, they don't just put a drug on the market without testing it to see if the good of the drug outweighs the harmful effects for the most number of people. Mullen mentions that if there are scientific gaps in areas that with standardization, they are more easily recognized, and new research should be implemented to further our understanding and use of treatments to fill in those gaps. No drug works 100% of the time, and there is no way to determine which drug is best, but having standardization gives a medical professional a list to choose from of drugs that have limited harmful effects and allows them to pick based on their expertise and knowledge of the patient. My ninth and final point is it does still take into account the patient and parent values. In Compliance Ethics Code 2.05D, clients being informed of rights and procedures, and the Code 4.02 involving clients in planning and consent. Standardization will require a greater accountability on the part of the staff to implement and choose the most effective plan for the client. It doesn't remove their responsibility to the client, but removes some of the steps in evaluating plans, hopefully making it easier to choose and implement, and explain to the parent. Mullen says that the choice between competing procedures cannot just be based on effectiveness, but also on the expertise of the BCBA and the client's wishes in order to be considered as a treatment. Just like with my example of the doctor administering pain management plan for a diabetic patient, the doctor can outline the choices available, but the decision on which treatment they're going to take is ultimately in the hands of the patient, and they will pick what best suits their lifestyle. Thank you.
Thank you for your rebuttal, Sarah. I just want to go back over and highlight her points one more time. The first point was that the plans can still be tailored to meet the client's needs. Plans should focus on the individual. Payment and reimbursement can be affected. It shouldn't take longer to train or cross-train, as BCBAs should already be training their staff in order to meet their Ethics Code 5.04. It will actually improve implementation by making it standardized. All plans still have to be generalized, so they should still be able to work in a variety of environments. It won't devalue or discredit professionalism or clinical expertise. It does have less experimental design, however, it allows for it and just has to be tested and proven. It does still take into account the patient and parent values. So next we are going to hear from Jessica on Team Con, and she is going to present the rebuttal, but also include salvager statements within her part of the debate.
Hello, my name is Jessica Lawless, and I will be speaking for the con side. I have 4 points as well, and my first point is standardization of evidence-based practices causes us not to be able to individualize treatment to meet each individual client's needs. Standardization of evidence-based practices also causes us to use treatments that only focus on the diagnosis and not on the individual themselves. My third point is standardizing treatments could be influenced by insurance policies and reimbursements. And my fourth and final point is standardizing evidence-based practices could cause us to leave out treatments that would be effective, especially with specific clients. For my first point, standardization of evidence-based practices causes us not to be able to individualize treatment to meet each individual client's needs. According to CASD in 2008, even if we were to narrow the evidence-based practices to just those with autism, given there is more research within that area, we are still asking inexperienced people to take an intervention and make it appropriate for all children. Using a discrete trial training program can either be very structured with no deviation, or it can be combined with a more naturalistic approach. Teachers may be fond of doing more structure in their approach to using this intervention, whereas an ABA therapist would be more likely to target this within the natural environment to encourage that generalization. Implementers may be biased in their approaches to some interventions regardless of what the standard would show or what the literature actually says about the version. My second point, standardization of evidence-based practices also causes us to use treatments that only focus on the diagnosis and not on the individual themselves. It's also another issue that Caston brought up. is that we may find out a client has been diagnosed with autism, and we immediately assume that the child needs something like a picture exchange communication system put in place. The child may have several maladaptive behaviors, and the teacher thinks he automatically needs that picture exchange communication system to help him communicate. Already be using some other type of speech-generated device, or maybe using verbals as a functional communication, but the teacher is going to automatically assume he needs PECS because he has autism and she's only focusing on that diagnosis. This can lead to treatment bias and stereotyping. For the third point, standardizing treatments could be influenced by insurance policies and reimbursements. This is another issue that Caston brings up in his argument in 2008, which says that standardization of practices is causing problems. So the standardization is often determined by a third party, such as a state legislature or others outside of the field, such as those insurance companies. Those who are determining the reimbursement and insurance companies are the ones standardizing the evidence-based practices in most situations, but they're not actually professionals in the field who know the type of practices that we should be using and covering. So they would possibly be leading to standardizing evidence-based practices that are truly not the best practice for the population that they are being standardized for. My fourth and final point, standardizing evidence-based practices could cause us to leave out treatments that would be effective, especially with specific clients. The issue here is that there are interventions that are not yet proven to be effective, but are being utilized on a daily basis, such as floor time and teach style teaching. Teach was on the emerging list back in the first phase of the National Standards Project, still being used. This technique continued to be used, even though it was only recorded as emerging. If standardizing treatments take place, then there will be a large amount of unstudied research points because people would only be allowed to use evidence-based treatments based on that cookbook manual. Thank you.
Thank you, Jessica. I'm just going to go back over her points one more time. Standardization of evidence-based practices causes us not to be able to individualize treatment to meet each individual client's needs. Her second point was standardization of evidence-based practices also causes us to use treatments that only focus on the diagnosis and not necessarily on the individual themselves. Her third point, standardizing treatments could be influenced by insurance policies and reimbursement. And then her fourth point, standardizing evidence-based practices could cause us to leave out treatments that would be effective, especially with specific clients. Now, you've heard the points from Team Pro and Team Con. Team Pro was represented by Mary and Sarah, and Team Con was represented by Kirsty and Jessica. All four ladies did an amazing job on the debate. I want you to know that I'm going to post the PowerPoint into the discussion board so that you can go back over these main points for both sides, and you can look at those and try to make your decisions based on that. Also, if anyone has any questions about the resources we used or anything that you need clarification on, I can also send you a copy of the resources under the discussion board for this video if you ask during your post. Thank you for tuning in, and I hope that the people in the hurricane's path stay safe and dry, and we look forward to hearing your discussion.